गर्न मिलिरहेको छैन।
सर अब
ओके
भयो होला।
ए हुन्छ। And for the another investigation to rule out the cause of epilepsy, if you are suspecting the structural reason in the brain, then we should go for CT scan and MRI. And if you are suspecting metabolic disorder, then we should go for urea and electrolytes, liver function test, blood glucose, serum calcium and magnesium. And to rule out inflammatory or infective disorder, we should check for complete blood count, erythrosedimentation rate, ESR, and CRP. And we should also go for chest X-ray and serology for syphilis and HIV or collagen diseases and CSF examination. And talking about the EEG, that's electroencephalogram and or magnetoencephalogram. EEG tests the cerebral function rather than the structure of the brain, and the epileptic form discharges on the EEG can help classify the seizure types, and it is used to assess the prognosis. And the neuroimaging, in the neuroimaging, we can go for CT scan and the MRI. And the CT scan, we can get a subdural hematoma or subarachnoid hemorrhage. Sometimes abscess might be present or neoplastic process and other space occupying lesion. And in the MRI is done for cerebral dysplasia or mesial temporal sclerosis. And when the history and the physical examination is suggestive of focal pathology and the CT does not show the cause, in that case, we should go for MRI. And the indication for brain imaging in epilepsy includes epilepsy starting after the age of 16 years, seizures starting after the age of 16 years, imaging procedure includes a PET scan, which it is used to detect metabolically active tissue, and what is used in detection of CNS tumors, and other is STEC, which is used to assess brain metabolism regionally, and it is more widely available and less expensive than PET scan. And the functional MRI, it is based on the fact that the cerebral blood flow and neuronal activation are coupled. It is not frequently used. The frequently used neuroimaging are CT scan and MRI, and another one is EEG. And talking about the differential diagnosis of the seizures, the differential diagnosis includes syncope, psychological disorders such as psychogenic seizures, and the metabolic disturbance such as alcoholic blackouts, delirium tremens, and psychoactive drugs. Sometimes the differential includes migraine as well, migraine with aura. And another one is transient ischemic attack, that's TIA, sleep disorder, cataplexy or narcolepsy, and the movement disorders such as tics, non-epileptic myoclonus. And the special consideration incidents include breath holding spells, migraine with recurrent abdominal pain and cyclic vomiting, benign paroxysmal vertigo, apnea, night sleepwalking. These are the differentials for the seizures. And talking about the features, which distinguish generalized GTCS from the syncope. And the features in the seizures, the immediate precipitating factors is usually absent, whereas in syncope it might be due to emotional stress or orthostatic hypotension or cardiac etiology. Premonitory symptoms, that is, there is no aura in seizure in case of seizure, is except in focal seizure, whereas in syncope the patient may give symptoms of tiredness, nausea, diaphoresis, and the posture at onset is variable in seizure, whereas in syncope the patient is usually erect, and transition to unconsciousness is sudden in seizure, whereas it is gradual over seconds in a syncope, and the duration of unconsciousness lasts for minutes in seizure, whereas it is usually lasts for seconds in the syncope, and the duration of clonic, clonic or clonic movements usually lasts 30 to 60 seconds in seizure, whereas in syncope it is not more than 15 seconds. Facial appearance during event in the seizure, the patient might be cynosed, or frothing from mouth, but in syncope the patient usually pallor, and disorientation and sleepiness after event is meant from minutes to hours in seizure, where it is less than 5 minutes in syncope. Biting of the tongue is usually or sometimes usually present in seizures, where it is really present in syncope. And incontinence, urinary incontinence, it is present in sometimes present in seizure. And in syncope also, the urinary incontinence might be present. And talking about the management include the treatment of the underlying condition, avoidance of the precipitating factors, and anti-epileptic drugs, and the management of the refractory epilepsy. This is the basic mechanism of seizures and anti-epileptic drugs. Actually, after you slide say. So after identifying the differentiating the seizure from the pseudo seizure or seizure from the syncope, now we have to know how to treat the patient with epilepsy or seizure. So we should know when to initiate the anti-epileptic drug. So we should start anti-epileptic drug therapy in recurrent seizures of unknown etiology or known cause that cannot be reversed. And the patient with single seizure due to an identified lesion such as CNS tumor, CNS infection, or trauma, in which there is strong evidence that the lesion is epileptogenic, then the patient should be treated. And the most patient with one or more of these risk factors should be treated. That is an abnormal neurological examination, seizures presenting as status epilepticus, or postictal torts paralysis, or a strong family history of seizures, and an abnormal EEG. If this one or more of these risk factor is present, then the anti-epileptic drug should be started. And then the drug of choice for the generalized uh, tonic-clonic seizure, the first line drug is lamotrigine and valproic acid. And in focal seizure, it is lamotrigine, carbamazepine, oxycarbazepine, phenytoin, or levetiracetam can be used in focal seizure as a first line drugs. And in typical absence seizure, valproic acid, ethosuximide, or lamotrigine can be used. And in case of atypical absence seizure, myoclonic or atonic seizure, the first line drug is valproic acid, lamotrigine, and topiramate. Then alternative drugs, you can go through this slide. So यो स्लाइडहरू अलिकति डिफिकल्ट छ है हेर्नको लागि हैन, द्याट इज यसमा चाहिँ डोज एन्ड एडभर्स इफेक्ट अफ कमनली युज्ड एन्टी एपिलेप्टिक ड्रग्स भनेको छ। यसमा चाहिँ तिमीहरूले याद गर्नुपर्ने भनेको चाहिँ हाम्रो फर्स्ट लाइन ड्रग्सहरू छन् सबैको, जेनरलाइजको, फोकल, टिपिकल, एटिपिकल, क्लोनिक र एटोनिकहरूको सबै यो ड्रग्सहरूको चाहिँ तिमीले डोज साइड इफेक्टहरू चाहिँ थाहा पाउनुपर्छ है। त्यसरी एकचोटि यो आफैले एकचोटि पढ्दा हुन्छ मैले भन्दा पनि हैन, यो फार्माकोलोजीतिरकै कुराहरू छ। सो यु गो थ्रु द्याट भन्छ है आफै। स्लाइडमा चाहिँ इन्क्लुड छ, अब यसमा क्लियर भएन देखेन भने अब फार्माकोलोजी बुकबाट हेर्दा पनि हुन्छ त्यस्तो। And further, we should know guidelines for anti-epileptic drug therapy. So how to start anti-epileptic drugs in a patient? At first, we should start with one first-line drug. We should start at a low dose and gradually increase dose until the effective control or seizure is achieved or side effects develop. Then the optimized adherence, that is use minimum number of doses per day. If the first drug fails, that is if the seizure is not controlled or if side effect develops, then we should start second line drug, followed if possible by gradual withdrawal of the first drug. If the second drug fails, then we should start the second line drug in combination with the preferred baseline drug at maximum tolerated dose. And if this combination fails, then we should replace the second line drug with the alternative other second line drug. And if this combination again fails, then we should check for the adherence and reconsider diagnosis. we should again go through the detailed history and identify whether it is seizure or not, or if there is any other metabolic disorder or any other causes. And we should consider alternative therapy such as non-drug treatments, that is epilepsy surgery or vagal nerve stimulation. And we should use minimum number of drugs in combination at one time. At one time, we should not go for more than 3 combined combination drugs at once. Usually हामी 2 ड्रग्ससम्म मात्र गएर हुन्छ होइन, अनि त्यसले पनि कन्ट्रोल भयो नि. if the seizure is not controlled, then we go on changing the drugs. Second line drugs are just change गरेर हुन्छ हाम्रो. So when to discontinue the therapy? Withdrawal of therapy can be attempted after 2 years of seizure-free interval in the patient who meets all of the following criteria. That is number one is complete medical control of seizures for 1 to 5 years. Single seizure type, either focal or generalized. A normal neurological examination, including intelligence and the normal EEG. In this condition, the therapy can be discontinued. In most cases, it is preferable to reduce the dose of drug gradually over 2 to 3 months. Then we can stop the drug. And the most recurrence occur in the first 3 months after discontinuing the therapy. And the other non-pharmacological treatment and surgical treatment includes, if in the temporal lobe epilepsy, there we can go for temporal lobectomy. If focal seizure is arising from the extratemporal region, then we can go for lesionectomy. When the cortical region cannot be removed, then we could go for multiple subpile transection. And hemispherectomy or multilobar resection can be done. And in case of disabling tonic or atonic seizure, we can go for corpus gallostomy. Vagal nerve stimulation is there, and implantable device can be used, or laser thermoablation can be done, or deep brain stimulation is done if the seizure is not controlled with medicine. And talking about the treatment of refractory epilepsy, for the treatment, actually there is no clear guidelines for rational polypharmacy, and in most case, initial combination therapy combines first line drugs, that is carbamazepine, oxcarbazepine, lamotrigine, valproic acid, and phenytoin. If the drugs are unsuccessful, then the addition of newer drug is indicated, such as levetiracetam, topiramate, or zonisamide. And if there is no improvement, a third drug can be added while the first two are maintained. If there is a response, the less effective or less well tolerated of the first two drugs should be gradually withdrawn. So these are the management of the epilepsy. And this is the algorithm for the adult patient with the seizures. यसमा सबै मैले अगाडि भनेको कुरा सबै यसमा इन्क्लुडेड छ है. सो यु गाइज प्लिज गो थ्रु दिस वान्स है. यसमा एक्सप्लेन गर्न अलिक धेरै टाइम लाग्छ. तिमीले एकचोटि आफै हेर्यो भने इट विल बी इजी फर यु है त. ओके, आजको लागि यति है. स्लाइड यति नै हो. के छ? मेरो थ्याङ्क यू भइसक्यो. कसैलाई के सोध्नु छ? हुन्छ ल, आजलाई क्लास यति नै गरौँ है त.
Thank you, sir.
Thank you, sir. Thank you, sir.
गुड टाइम है त. म स्लाइड पठाइदिन्छु तिमीहरूलाई, अनि सेयर गर्नु है सबै. हुन्छ ल.